How does AMH inform the amount of medications that a patient will need to receive in IVF? When we do an IVF cycle, we're aiming for somewhere between, let's call a broad range, 10 and 25 eggs. And there are some patients that won't be able to retrieve 10 eggs because they have low egg reserve and our target is lower. There are some patients who have 50 or 60 eggs in the ovaries, and we're not trying to get 50 or 60 eggs. There's a condition called ovarian hyperstimulation syndrome where you get too many eggs from the ovaries. The ovaries can put out a factor called vascular endothelial growth factor, or VEGF, which is a protein released from the ovaries with ovulation. And if you ovulate too many eggs, that VEGF can leak into the systemic circulation, make blood vessels leaky, and predisposed to blood clots, fluid in the lungs or abdomen, extreme discomfort. And so, we want to be greedy, but not so greedy that we're putting the patient at any serious medical risk. For patients who have very low ovarian reserve, dosing is based on the number of eggs in the ovaries and their height, weight, and calculated BMI. So for someone who's very thin, who we're not expecting to get more than 6 or 7 eggs, oftentimes we see those patients on maximum dose medications, 300 units of Gonal-F or Follistim, or even 450 units and 150 units of Menopur. But that's pretty wasteful to the patient's finances and maybe giving the patient more side effects. So what we know is that for patients with low ovarian reserve, reduced dose stimulation protocols have equal success rates to high dose stimulation protocols, but maybe less side effects and definitely cost savings because the medication is very expensive. So for someone who has a low AMH, dosing really should be based on their body mass index and enough medication to get all the follicles that are present to grow, but not more than is needed so as to be wasteful. Where nuance really comes in is for patients with extremely high ovarian reserve. Let's say we have a patient with 70 follicles in the ovary. I want to get 20 eggs for that patient. Her fertility goals are such that she wants to have a robust supply of eggs for her IVF cycle. Now we know that women who get more than 10 eggs in an IVF cycle do better than women who get 5 eggs in terms of just the efficiency of the treatment. We know that women who get 15 eggs in an IVF cycle do better than those that get 10. The literature would show that women getting more than 15 eggs actually don't have higher individual success rates per cycle. So 15, maybe 20 eggs is a sweet spot in IVF where the ovarian hyperstimulation syndrome risk is tolerable, but it's a very efficient cycle and cost effective. Now for any individual patient, we might be shooting for lower. If I'm seeing a professional athlete who needs to be on the field during her IVF stimulation, it may be that we're aiming for 4 or 5 follicles so she can still perform at her elite level. So everything has to be, this is general. We're talking about generalities here, and everything has to be specific to the individual patient. So imagine that I'm a cattle farmer and I have a big fenced off area with 200 cattle, and I need to move 20 of those cattle from one side of a large swinging fence to another. And I'm given 2 minutes with which to control the flow of cattle from one side to another. If I open that door all the way, there's a stampede, and pretty much 200 cattle are going to go from one side to the other. If I open that door just a little bit, one cattle is going to slowly walk over the 2 minutes, and maybe 8 or 9 cattle are going to be on the other side. So what we do with fertility dosing is not that different from the rancher who is opening that door slightly and then controlling the flow of his or her cattle from one side to the other by how much that large swinging door is open. So if I have a patient with very high ovarian reserve, I have to be very careful about how much I open the door. If I open it too little, and each individual patient has very specific response rates. I might have 2 patients that weigh 120 pounds, same AMH, I give them the same dosage of medication, and one is on their way to getting 50 eggs, and one is on their way to getting 10. So there's just unknowable, you have to stimulate first to see how they're gonna do. So we pick what we think is a safe starting dose, and then we have to feather the opening of that door by either going up or down on medication, sometimes on a daily basis over 2 weeks. And that's why patients with high ovarian reserve need more frequent monitoring and a more nuanced dosing of the medication in IVF.